living La Vida low carb. This show is changing lives. We talking about your diet, trying to get you feeling right. Cut up them avocados, fry some eggs, time to explore the longest running health podcast, hosted by Jimmy Moore. Time to give up the crappy garbage, we're getting into ketosis. Every day is a new step to your goal, yeah, you're getting closer. Motivated and focused, don't stop, just go. Time to get inspiration from the Living La Vida Low Carb Show. Hey, the livinglowcarbshow.com.
So guys, that right there is Dr. Philip Ovadia. He is a cardiac surgeon as well as a metabolic health physician, and you'll find out soon why the metabolic health part is so critical to this. He's trying to teach people how not to have heart surgery. Even though you make a lot of money doing that, you don't want to have to do that anymore. So he's got this new book out, you guys. Go check it out. Stay Off My Operating Table. I love that. That imagery is so great, and you've got all these meats and vegetables and fats all there on the front cover of your book. So
thanks for
welcome to the show. Thanks for being here.
Fan for quite a long time of everything you do.
You know where I found you? Thank you for that. Where I found you first was on Clubhouse, of all things. You were like doing the rounds on Clubhouse, and I'm like, who is this Philip Ovadia? It's like I looked you up, and I'm like, oh wow, he's done a lot of good things. And the fact that you're into the ketogenic lifestyle as a metabolic cure, and then through that improving people's cardiometabolic markers, it's great, and keep people off of operating room tables. It's beautiful. But let's back up, because not every cardiologist, heart surgeon is into nutrition. They're into making the money from the procedures and statin medications and all the things. How did you get involved in medicine, and then how did it shift from allopathic care to more of kind of a functional medicine,
so,
which sounds like what you're doing now?
My personal and professional stories really overlap a lot. I was always obese, overweight as a child, and this was despite, following all the mainstream advice, following the U.S. dietary guidelines, very active as a child, played sports years round, but just found myself getting bigger and bigger. And I went through college and medical school, and that continued. And a couple of times along the way, I tried to lose weight. I counted my calories, I ate a low-fat diet, and I would lose a little bit of weight but then gain it back, and more usually. And I know that's something that many people in your audience can relate to. And about 5 years ago, I really found myself as a crossroads. I realized I was going to end up on my own operating table. I was morbidly obese, I was pre-diabetic, and I knew I was headed down the same path as the patients that I was taking care of every day. But the same advice I was giving them was failing me. And thankfully at that time, I came across Gary Taubes and, learned about the different theory about why we get obese and why we get unhealthy, that it might not be so much how much food we eat, but the types of food that we eat. And I, immediately cut out sugar and went low carb, keto, ultimately carnivore. I've now lost over 100 pounds and maintained that over a 5-year period. And more importantly, I came to realize that what helped me was what was going to help my patients. Because I learned the truth about what causes heart disease, and it's not, what we've been led to believe. And now I work with patients. I continue to work as a heart surgeon, but I also now try and help people to stay off my operating table and prevent heart disease and all the other chronic diseases that we deal with by focusing on metabolic health.
You are such a breath of fresh air, Bill, because I see a new declaration from the American Heart Association just this week on saturated fat. And can you tell people that might not have heard about this what the position is on saturated fat, that they came out with this big statement as it relates to your cardiovascular health?
The day before, as you said, the American Heart Association updated their dietary recommendations, essentially, what we should be eating. And quite frankly, they're an embarrassment. It is the same advice that they have been giving now for 40 plus years. The results are all around us. Heart disease remains the #1 killer in the United States and worldwide. as you know, many in your audience know, 88% of the adults in the United States are not metabolically healthy. Our obesity, you know, rates are skyrocketing, especially in our children and our young adults. And, you know, clearly their advice is failing, and all they can do is continue to double down. And, you know, of the 10 dietary, you know, kind of guidelines that they put out the other day, I can honestly only agree with one of them, which was to eat fish and seafood, you know. Otherwise, I mean, they actually continue to recommend that we use processed plant and seed oils instead of natural animal fats. And it is just crazy. And it has never been proved to, you know, benefit our health. And they are so focused on just lowering LDL cholesterol levels. And that's what all their recommendations are based around. And again, it's just failed advice that we need to start pushing back against.
Which is shocking to me that they're still on 50-year-old science. Like, we were talking about LDLC 50 years ago, and here we are in 2021, almost into 2022. We know so much more about cardiovascular health today than we've ever known. We know about triglyceride to HDL ratio. We know about having a heart scan and seeing if there's actually atherosclerotic plaque in those arteries before you cut someone open. We know about inflammatory markers and their importance, and that you really can't have heart disease unless you have inflammation. It seems like they put all the emphasis on LDL. They pushed all their chips all in, and they have a 7-2. And they're going up against pocket aces, to give a poker reference.
Yeah, that's exactly it. And, you know, we of course, you know where the majority of their funding comes from. And quite frankly, you know, they have built their reputation on this advice, and it is just hard for them to change course despite, you know, the mounting evidence against it.
Yeah, I tell people, if you see that American Heart Health symbol, that is a food you avoid. And literally, you go up and down the aisles, you'll see it on cereal, the American Heart Association thing, and then on all the vegetable oils. And the reason is that LDL. And look, it does lower LDL, but it's at the expense of the rest of your health. Yeah, LDL goes down, but that doesn't mean you got healthier.
Yeah, that's exactly it. And, you know, ultimately, I tell people that most of the food that you should be eating shouldn't even have a label on it. So you don't even have to worry about having that stamp of approval. Just eat whole, real food. And that is what is going to make us healthy and keep us healthy.
Yeah, Gina said the same with the American Diabetes Association. But although Gina, a few years back, the new president of the ADA is actually a low-carb person. And so she came in, she's like, all right, keep promoting the ADA diet, but we're going to add a low-carb option for people that want that. So ADA is far better than the AHA. I get so nauseated with the AHA because they don't have any, I guess, chutzpah within them to want to look at the science. There's a lot of science on cardiovascular health and better metabolic health. A lot of science, and yet they ignore it.
You have to go back to their funding and their history. You know, this is what they were established based upon. The American Heart Association was a, you know, a foundling, you know, struggling organization prior to, you know, Ansel Keys coming along and, you know, pushing the narrative about saturated fat, getting the funding from the food companies and now the pharmaceutical companies, and they really just can't change their ways. And, you know, as much as I disagree with the U.S. dietary guidelines and the food pyramid, even within the U.S. dietary guideline, the committee behind that in both of the last revisions, 2020 and 2015, say that saturated fat should not be considered a nutrient of concern. And that
well, it was dietary cholesterol, they said, shouldn't be a nutrient of concern, but they've even like moderated their limitation on the saturated fat, so you don't have to limit it down. I think at one point they had it down to 8% calorie. Now it's about 15, which is still, I think, too low.
Yeah,
but
exactly.
They're moving in the right
really,
direction.
The American Heart Association seems to be the last holdout that is, you know, kind of clinging to that concept.
You know what I think our ace in the hole of getting all this to change is, Phil, is the events of the last 2 years. Like, if we haven't had a bright light shining on metabolic health before this pandemic started, we sure got one on it now. And I think it makes people realize, holy crap, what have I been doing to myself? I think the party is over. It's time to clean up the beer cans and flip the couch back over and get everything back in order again, because for the first time in a lot of people's lives, they see why metabolic
really
health is so important.
True. You know, unfortunately, we're not getting that messaging from, you know, the leadership, but more and more, you know, I think it is incumbent on people to take charge of their own health. You cannot depend on the healthcare system. You cannot depend on the government to keep you healthy ultimately. Again, we look all around us, we see the results that their advice is producing. And if you want to be healthy, you simply can no longer follow their advice. Yeah, I know.
Been saying that for years, brother.
Obviously, being in the healthcare system, it's increasingly frustrating to me. But I do have hope. You know, there is a growing community of physicians. You know, I go to the low carb meetings. I interact with, you know, more and more doctors who are coming to understand this. But it is difficult because the whole system is constructed around taking care of sick people. It is not geared towards keeping people healthy. And that's why I think, you know, we need to start going out of the system. And the things that I am doing, you know, while I continue to work as a heart surgeon, I also now have a, you know, online telemedicine practice and an online community where I work with people either one-on-one or in group settings to help them understand these concepts. My book, which, you know, thank you for holding that up and promoting it. It's coming out. Yep, OvadiaHeartHealth.com is where all the information is. My book releases next week. I'm proud to say it's, you know, the #1 new release in heart disease on Amazon currently. And it's got, you know, all the information that people are going to need to take back control of their health.
And those of you that listen on the podcast, when this airs at a later date, it's already out. Go get it. It's available right now. But the rest of you go pre-order it. As an author, I love the pre-orders because then you kind of know, all right, what's the vibe, the buzz for it. So, and good for you. That's going to be a wonderful book. Let's get into our hands dirty a little bit, because the allopathic care looks at total cholesterol and LDL, and that's like the be all end all is those two numbers. And so they predicate putting you on a medication based on those numbers. They predicate, okay, we need to take, you know, more aggressive action to deal with it, but they never really tell people what all those other numbers mean. So triglycerides, so critical. Inflammatory markers, if they even run like a homocysteine or a IGF-1 or an HSCRP, I don't know many doctors that are like routinely running that. They'll run the cholesterol, but they won't run those tests, and they're not expensive tests. And looking at blood sugar and insulin levels, like all of that is related, because heart disease isn't of eating too much saturated fat and cholesterol. It's an inflammatory thing, and you're getting inflamed because of carbohydrate.
Yeah, I
and
think
because
that
of
sums
vegetable
it up
oils.
well. You know, I emphasize to people that you need to first and foremost pay attention to the 5 markers of metabolic health. So, you know, marker #1 is your waist circumference. You do this at home. You take the tape measure just above the level of your belly button, measure it first thing in the morning. If you're a man, you want that to be less than 40 inches. And if you're a woman, you want it to be less than 35 inches. Measurement #2 is your blood pressure. If you are already on medication to lower your blood pressure, that is a sign that you are not metabolically healthy. Without medication, you want your blood pressure to be less than 130/85.
So I went to give blood the other day, Phil, and when they tested it, I must have been nervous about giving blood and having the needle. It was 177/105, and they're like, "Sir, that's too high to give blood."
Yeah.
I'm like, "That's too damn high anyway. Like, what do I need to give And I'm like, give me 5 minutes. I'm gonna like chill a minute. And they came back in, and it
Yeah,
was 120 over
exactly. You
74.
can't
I'm like,
go off of one measurement of this. It's easy enough. You can check it at home. You can go to any grocery or pharmacy these
Right.
days, and they usually have the cuff, or you go to your doctor and get it checked. The other three measurements we look at are all blood work. So your fasting blood glucose level, you want that to be less than 100 without any
Yes.
medication. So again, if you're type 2 diabetic, you're already metabolically unhealthy. Fasted, correct.
and
yeah,
in a
8 to
fasted
12
state,
hours
not
fasted.
post-prandial.
And then you look
Right.
at your cholesterol numbers. But importantly, we don't look at the LDL cholesterol. It is not a factor in metabolic health.
It's the only marker that's guesstimated.
Correct.
It's not even like directly measured. And most
Yeah. So
know
look at
that,
those
Phil.
other
That's the
two
funny
measures,
part.
your HDL cholesterol and your triglycerides. Those are numbers 4 and 5. HDL, good cholesterol as they call it, the higher the better. If you're a woman, you want it to be over 50. If you're a man, you want it to be over 40. And then you look at your triglyceride level, and you want that to be less than 150 by the official criteria. I think that's too generous a number, but, officially under 150.
Too high.
And if 3 of those are abnormal, you have metabolic syndrome. It is a medical diagnosis, and it means that you are at high risk for diabetes, heart disease, many forms of cancer, Alzheimer's disease, kidney problems. All of these things come from poor metabolic health. If you have 1 or 2 of those abnormal, it's a warning sign, though, because we know that people with 1 or 2 abnormal today are likely to progress and have 3 or more abnormal in the future. And if they're all within range, congratulations, you are one of the 12% of people who is metabolically healthy. And, we need to get that number up. We need to get more people metabolically healthy, because poor metabolic health has been shown to be the #1 risk factor for heart disease and all of those other chronic diseases that I mentioned. When you look at the top 10 causes of death in the United States every year, 7 of the 10 of them are related to poor metabolic health. And oh, by the way, this past year, it was 8 out of 11, because we added COVID, which is clearly related to poor metabolic health.
Right. Which, if people haven't figured that out by now, I'm sorry, I don't know what to tell you. It's so obvious. Like, what was it? Something like 80-something% of the people that end up dying had at least 2 or 3 comorbidities. So take for that what you want, people. Yeah, I have one of those, by the way, the waist circumference, and I'm working on that. I'm in the midst of doing a lot of biohacking to try to move that needle, but all the rest of those markers well within the comfortable range of healthy. And so I'm working on it. I'm not letting that be my bugaboo. Plus, I'm fighting a lot of genetic factors. I had heart disease in my family. My dad had a heart attack at 48 and another one at 50, and then quintuple heart bypass on your operating table at 54. My brother Kevin had 3 heart attacks at 32 and then ended up dying at the age of 41 from the heart disease. I had grandfathers, both died of heart disease. I'm about to turn 50. I'm supposed to get heart disease according to genetics. And I've got epigenetics on my
what
side.
I tell people, genetics plays a role, but it's not a life sentence. And, in the end, genetics is probably only about 5 to 10% of this. Diet is the big thing. What we eat is the main determinant of our health. And we need to recognize that. We need to talk about it. And then we need to give the actual good advice about what to eat, not the garbage that the American Heart Association is pushing out there.
Keto can be hard. Tabulating, measuring, baking, taking 3 months to perfect one recipe, and to mixed reviews.
Did something die in here? Oh, I think it moved.
And by that point, you give up your diet, find a dark corner, and stuff yourself with sugar, carbs, and regret.
This, isn't what it looks like.
Well, this is where Keto Chow saves the day. The easiest, tastiest, ketoist meal replacement on the market.
It's like ice cream melted in my mouth.
Yes, but melted ice cream with all the protein, nutrients, vitamins, and electrolytes your body needs.
Oh, that's cool.
And with 3 starter kits, each with restaurant tips, keto food guides, and a ton of flavors to try, your taste buds And your waistline. Well, thank you.
Thank you.
So grab your starter kit today at jimmylovesketochow.com.
It's so easy.
Keto Chow. Make keto easy.
Well, that's where we get into trouble. Doctors say, well, go eat better. When then people read materials from like the American Heart Association, oh, well, they say cut your fat and your red meat, and so I'm eating better. And then that doesn't help them. And they actually go on a statin medication, they're eating their low-fat diet, and they get frustrated, and then they have a heart attack.
That is the common question that I get, and that's why I wrote this book. All of the patients who end up on my operating table, that's what they say. Why did this happen? And, a lot of them, it's obvious, they're smoking and they're eating, processed food and fried food and all that all the time. But many of them are. And so we need to start questioning that advice.
And on top of the nutrition, which I think is paramount, you definitely understand that very well. I think people live too stressed in their life as well, which is why I implemented a lot of relaxation techniques. I do a lot of deep breathing, kind of meditation. I got a hot tub that I chill out in. I do a lot of like mindful chilling out because I know that sympathetic state.
Yeah, in my book, I actually outlined 7 principles of metabolic health, and eating whole real food is one of them, but I talk about reducing your stress, getting adequate sleep, moving more. These are the other, pillars that are going to contribute to your metabolic health.
So, Gina, I have a question about statins, why they're used so much and why they're harmful. And we could go on and on about that. I wrote a whole book about cholesterol as well, called Cholesterol Clarity, and did a whole just on that. And it seems to me now that they're no longer a name brand and they're kind of off brand and they're pretty cheap to get a statin, now they're saying, well, you need a statin plus. And so talk about some of the new medications that they're trying to promote to lower cholesterol, which would ostensibly lower your heart disease risk, is what they think.
Yeah,
why maybe they don't do what they say they do.
Now where, statins have been the most widely prescribed class of medications for the past 20 plus years. And it has not had a noticeable effect on the incidence of heart disease. So, a logical person would look at that and say, maybe statins aren't the answer. Maybe lowering cholesterol isn't the answer or the only answer. But instead, organizations like the American Heart Association double down and say, well, we must need to get patients' cholesterol levels even lower. And so there are new medications out. The PCSK9 inhibitors are kind of the big thing there, but there are some additional ones. And, they are now recommending that people, get their cholesterol as low as possible. Like 0 is literally the goal for some of this, and it's insanity. Cholesterol is in our bodies for a reason. We have plenty of good data that's showing having a low cholesterol level is a risk to your health. The mortality, when you look at the overall mortality, exactly, your brain is made of cholesterol. Cholesterol plays a part in fighting off infectious diseases in your immune system. Cholesterol is the precursor to all of our sex hormones, testosterone in men, estrogen, progesterone in women. Cholesterol plays a very important part in our bodies. And to just say that we should try and eliminate it essentially from our bodies is crazy.
Well, and it's crazy because there's so many like hormonal pathways and vitamin D synthesis. Like there's so many good things. I remember Sally Fallon Morell was on my podcast many years ago from the Weston A. Price Foundation. That I want my cholesterol as high as possible. And I was like, yeah, like it's sacrilege to say that in our day and age because it's been so vilified. Cholesterol in the body's been so vilified, but it's true. And even like in my research for Cholesterol Clarity, they looked at a lot of the traditional tribes to see what like their normal cholesterol was as they got older. And the older you got, more cholesterol you wanted because it's anti-inflammatory, cholesterol is, and it just has so many good properties, and it's the boogeyman in your health.
Exactly. Again, this all started with the flawed concept. We looked at a group of people who had very high cholesterol levels, familial hypercholesterolemia. It's a, genetic issue. And some of those people had heart disease. Important to point out that not all of those people get heart disease. But even, within those people with exceedingly high cholesterol levels, there seemed to be an increased incidence in heart disease. It got blamed on the cholesterol, and then it just became a self-feeding sort of narrative that we need to lower everyone's cholesterol as much as possible. And the science simply doesn't support it. And you look at the benefits that we get out of lowering cholesterol, and they're nowhere near as much as the drug companies would lead you to believe.
Well, look what they did. They manipulated what normal cholesterol is. So that 200 number that's kind of been the gold standard, they keep trying to push it down to 170. But the 200 number that they settled on, it's the only number that I'm aware of, maybe you can correct me if I'm wrong, but of all the different numbers on all the different parameters, usually they try to go kind of 80th, 70th, 80th percentile of, okay, if you're above this line of 70th, 80th percentile, more likely to be at a disease risk, and if you're below the line, you're less likely. Well, guess what it is? That 200 represents the 50th percentile. So they're saying half the population is diseased and half isn't.
It really is.
That's ridiculous.
I see it every day. About half of my patients that end up on my operating table for heart surgery have low or normal cholesterol levels. Sometimes because they're on medications, sometimes without medications, but they're still ending up on my table. And so, again, we need to take a step back and say cholesterol can't be the answer. There's got to be something else going on, and that something else is clearly metabolic health.
Yes, which then translates into higher inflammation markers. So that's one thing that could be looked at. Also CAC scores, the heart scan, and get the heart calcium score. Nobody's on your operating table that doesn't have a very high CAC. Again, when we look at the data, the recent study came out of the Women's Health Initiative where they looked at, the risk associated with only having a high LDL cholesterol level in terms of heart disease. And it was about a 1.2x risk factor, a small risk factor. When you look at insulin resistance is what they measured in that study, but metabolic health, it is a 6x risk factor. So, why are we so focused on the cholesterol part of it and no one talks about the metabolic health part of it? How did they measure the insulin resistance? What were the markers?
The LPIR score, which is one of the literature measures.
Yes. So there's a test from this company called Liposcience, you guys, called NMR lipoprofile test. And one of the markers on there that I love that they do that is this LPIR score. And it's an insulin resistance score. It's on this spectrum. And if you're on the lower end of the spectrum, it's less insulin resistance, more insulin sensitivity, and the higher, worse. And they're all on the high end is what you're saying.
Advanced testing, simply looking at your triglyceride to HDL ratio. Again, it's on your basic cholesterol panel. It's part of your metabolic health measurement. And if that ratio, the triglycerides divided by your HDL, is less than 2.
So looks like Donnell has a question about statins and whether you have a high CAC score, if the statin will help. That's not what the statin does, is it?
Statins have not been shown to reverse undo CAC scores, lower CAC scores. In fact, the data goes the other way. It shows that statins oftentimes raise CAC scores. And, there's some debate about, whether that's beneficial or not. I would say probably not. But, I think we have clear data about the flip side of that question. If your CAC score is 0, there is clearly no benefit to statin therapy. Right. So no
matter what your total cholesterol is.
Correct.
Yeah.
Correct. And that's been very well shown in the literature. If you do have an elevated CAC score and an elevated cholesterol, you know, there is a discussion to be had about whether or not statins may benefit you. But that is a very, you know, nuanced discussion.
Yes.
You need to be working with a practitioner that understands this very well. It cannot simply be a checkbox that, you know, your LDL cholesterol is high, you should be on the statin. There are many factors that go into it, things like inflammation, insulin resistance, your types of cholesterol particles that you have. All of this needs to be factored in.
I remember interviewing a general practitioner who's into kind of ancestral diets, keto diets. And I said, is there anybody that you recommend in your patient population that they go on a statin? He said, if they refuse to do the diet, I feel like I have no other choice but to throw that at them to try to at least acquiesce some of the impact of their metabolic health from their crappy diet. And I'm like, wow, that's depressing.
Yeah, I mean, and I would agree with that. And yes, there are some patients who benefit from statins.
Yes.
It's just nowhere near as many. You know, when you look at the data on statins, for instance, everyone who gets put on a statin for LDL cholesterol above 140 without a history of heart disease, you know, we know that what we call the number needed to treat is about 1 in 300.
Yes.
So that means 1 out of the 300 people every 300 people that get put on that statin, one of them will benefit.
Right.
So, you know, we need to do a better job of figuring out who that one person is.
Right.
And stop, you know, wasting the resources on those other people.
Well, wasting resources and the unintended consequences to those 299, because a lot of them get the muscle aches and pains, and a lot of them have increased risks of things like diabetes and cancer, and even heart disease risk for a lot of people taking a statin. Like, that shocks people when they find out there's like a 12% increase risk of heart disease, taking the thing that's supposed to prevent a heart attack, at least in the minds of the public.
Yeah, you know, I think in the end, you know, I don't say that statins have no use, but they're very overused and they're not used in the proper situations. And we need to do a better job. Physicians need to do a better job of doing that. The problem is, again, the system is geared towards, you know, getting everyone on a statin. The way the system looks at it is, you know, we are okay with, you know, treating 299 people who aren't going to benefit to make sure that that one person, you know, gets the benefit. And I think that's just the wrong approach. And, you know, more importantly, I think it distracts from the conversation around you can do other things to lower your risk of heart disease. You can change the way you eat. You can change your lifestyle and meaningfully lower your risk of heart disease. But we don't ever talk about that because most physicians just say, take the statin and that's it.
Well, and there is one genetic test people can have run. It's a part of your cholesterol, advanced cholesterol panel, called ApoE4 or ApoE genotype. And it's the 4 that you have to look out for. So if you're a 4-4, every cardiologist I've ever interviewed on this show, they're like, if they're a 4-4, we're going to throw the kitchen sink at them because usually they're at great risk for heart disease. Do you run ApoE genotype with your patients?
You know, I do some. I you know, look at other tests, things like LP(a) as well. There are a lot of tests that can help us predict risk. But ultimately, even when you look at those people with 4-4, you know, ApoEs or high LP(a), you know, the inflammation, the metabolic health is still more important. You know, and so we need to address that part of it and not just focus on the cholesterol part of it.
Agreed. Point. A lot of cardiac is by the way, a lot of cardiac patients, they think getting a stent put in and having an angiogram and bypass, that fixes the issue. No, that's a band-aid on what caused you to begin with. Because if you don't make changes, which most people don't, if you opt for those bypass surgeries, you're basically saying, okay, well, I don't know what happened. Let's bypass it. And that new one gets clogged.
Yeah, exactly. You know, there is a high rate of reintervention, we call it, you know, in the medical term, after both stents and heart bypass surgery. And again, it's because we are not addressing the underlying problem. The surgery, the stent, neither of those are going to address the metabolic health, the inflammation. And we, again, we need to do a better job doing that. And that's, kind of part of my new mission, is to get that word out there and to help people, ideally stay off my operating table. But even if you end up on my operating table or someone else's operating table, there is still benefit to doing this afterwards. You can still lower your risk of ongoing damage and ongoing impact from heart disease.
Oh man, I remember when my dad came home from that quintuple heart bypass surgery. It's just under 20 years. And they gave him this one sheeter, and I'd already started eating low carb. And I took a look at the one sheeter, and it said no salt, no saturated fat, no red meat. And I'm like, what do you eat? Cardboard? Like it was like shocking and horrifying. And I'm like, Dad, it said eat margarine. I was like, Dad, I'm really going to follow this. Oh, well, that's what the doctor says, son. Of course, he's of that age, in his early 70s, that they kind of still have the white coat syndrome, and they believe that. My generation, I'm turning 50 this year, we say, screw that. I'm going to question everything.
Yeah, and that's really what people need to start doing. I encourage that. You are the best advocate for your health. You can't rely on the healthcare system. Unfortunately, you can't rely on your physician blindly.
Right.
Your physician should be a partner. He should be educating you, helping you make the choices that are going to support your health. But ultimately, you need to be in charge of your health.
Hear, hear. That is the theme song of my life's work the last 17 years. So if none of that is heart healthy, tell us, in your estimation, Phil, what is a heart healthy diet for people to fix their metabolic health, which then in turn helps them be healthier in their cardiovascular health?
Yeah. So in my book, I don't give the Dr. Ovadia 28-day diet plan. There isn't one diet plan for everyone. What I do is I go through many of the popular diets of the day, literally both carnivore and vegan, and low carb, keto, Mediterranean, paleo, gluten-free. I talk about all of these. And I talk about what is metabolically healthy about them and what is not metabolically healthy about all of them. And what I encourage people to do is to understand the framework that supports metabolic health. The 7 principles that I lay out in my book. Eat whole, real food is, first and foremost, and then find the dietary strategy within that works for you.
Yes.
And, for me personally, it's been, carnivore for the past 3 years and low carb and keto for, 2 years before that. But that doesn't mean that I think everyone needs to be carnivore or low carb or keto. You need to find what works for you. You need to be measuring the proper metrics, the measures of metabolic health we talked about, and use that as your guide. If what you're eating is keeping you metabolically healthy and making you metabolically healthy, then great, keep doing it. But if it's not, if those numbers are getting worse or not improving as they need to, then you need to find a different strategy. And I hope within my book, there are lots of different strategies that you can look towards to find what works best for you.
And I love that, Phil. I love the fact you're not dogmatic. You're not calling yourself the carnivore cardiologist. You're not trying to, I guess, pin yourself into the corner, knowing that patients are very unique. They're going to have very unique metabolisms. Maybe they fall within that 12% that's generally metabolically healthy, but then maybe they smoke. Maybe they have extra stress, and that would cause problems on their heart that then they could fix it as well. I love that it's kind of a total approach. It's not just this, let's just throw some stuff up against the wall and see what sticks.
Are you tired of playing the mask game? Me too. That's why I wanted to tell you about the Unmask. This is a breathable, completely breathable. It covers, you can't even see that it's breathable, but it's breathable. Whether you're going on a plane, having to go into a store and wearing this thing, playthemaskgame.com is how you can get this mask. They come in all kinds of colors and everything. In fact, right there, you can see right through it what it is, but when you're wearing it, it does not look like it's anything different, but it's breathable, baby. Playthemaskgame.com.
If someone is concerned about their heart health, Phil, we've already mentioned a few of the tests to keep an eye on, and their doctor is just adamant. They're just going crazy about the LDL being high. the total cholesterol being too high. Oh, I need to put you on the statin. I need to try you on one of these newfangled cholesterol lowering medications. What can patients do to kind of counteract that, to maybe say, hey, wait a minute, pause, run this test, run that test? What are some other things before they go on any medication or do any procedures that they could push back with?
Yeah. So, I think that asking, those questions that we kind of mentioned, what is the true benefit that I'm going to get from these medications? Give me the numbers, give me the data. And, if your physician can't, unfortunately, sometimes the answer is you need to find a new physician.
Yes.
But hopefully your physician is going to be curious enough. You can bring them my book, your book. Asim Malhotra just wrote a great book as well, on cholesterol. And ask, say, hey, here's a heart surgeon saying this, what do you think about this? And if they're not curious enough, if their only answer is, you need to be on statins, no questions asked, then sometimes, unfortunately, they're just not the right doctor to work with. A doctor who isn't curious, I think, is the most dangerous doctor there is. I have in my book some resources for trying to find a doctor. Ultimately, I think, using your networks, whether it's in real life or online, like this, ask in the communities, find the people who are getting the results that you want to get, and find out who they work with, is a great strategy for finding a good doctor.
Definitely finding a good doctor is helpful. As far as like challenging your doctor, don't be afraid to, by the way.
Exactly.
Human, I could talk to you and you're a wonderful speaker and you've got lots of knowledge, but that doesn't mean you are the boss of me and you say, well, this is what you're going to do. You're kind of a consultant. And so I tell patients, don't be afraid to challenge your doctor. Okay, ask about the numbers needed to treat number. Okay, how do you explain that? Da, da, da. And if they don't know the answer, then you can say, okay, let's go back to the testing route. Let me have a CAC score. Let me find out what that is. Because if it comes back a big fat 0, as you said earlier, that total cholesterol is meaningless. Same with maybe a carotid intima, the CIMT that can have run to look for the thickness of the carotid artery. That's another great test. If it comes back wonderful, again, you have nothing to worry about. The NMR or other kind of particle tests is another one, that if the preponderance of your LDL particles are the large, fluffy, and buoyant kind and not the small, dense LDL, like you mentioned earlier, that's another great sign. It's probably not a big deal. So there's so many things that before you stick a pill in your mouth, you guys, that you can ask your doctor about.
Yeah, and understand that the CAC score is actually in the guidelines now.
Yeah.
And many physicians don't realize that,
It got added 2 years ago. It just got added to the guidelines because there was a came out called Widowmaker that really hyped up the CAC score in the heart scan. And yeah, they added it, but it was like under hushed tones. Shh, don't tell anybody, even the doctor.
Yeah, exactly. Exactly. They don't very well publicize that to the doctors, but the guidelines say that if your only risk factor is an elevated cholesterol level, that a CAC score should be used to determine whether or not you'll benefit from using a statin.
Yeah, it's amazing to me how many of the things that are so available to us, readily available to us, that we're not using when it comes to our cardiovascular health. And yet people still just want to trust the LDL-C and the total cholesterol, and if they're out of whack, suddenly I'm highly diseased. And it's like, actually taking that medication and eating the way they tell you to eat makes you more diseased. So then it becomes a self-fulfilling prophecy of the heart disease developing. All right, guys, it looks like we're frozen again. So I'm going to go ahead and remind you that that's Dr. Philip Ovadia. Go follow him over on Instagram, Ovadia_heart_health. Go follow him there. He does have this brand new book. Go check it out. Stay Off My Operating Table. It's available on Amazon. And when we get him back up here, we'll let him say goodbye. Thanks for hanging in there with all the technical issues, but we're at the end. I want to let you say goodbye, Philip. So thank you so much for being here today. And it's been a wonderful conversation. I love talking this stuff. It's all nerdy, but thank you so much. So sorry you kept dropping off, but we made it to the end. Thanks for being here.
Perfect. Thank you, Jimmy.
So guys, go get his book. again, stay off my operating table. Check it out. And is it Kindle and paper or?
Yeah, there's a Kindle and a print version, and they're both on Amazon and barnesandnoble.com and all the other online booksellers. And if you go to my website, ovadiahearthealth.com, it also has all the information about joining my community or signing up to be a patient in my practice.
Awesome, dude. You need to start your own podcast. I think you'd be pretty amazing.
I have a podcast. It's the Stay Off My Operating Table podcast. It just launched about a month ago, and it is. I encourage people to go check that out as well.
Yeah, that was a softball because I knew you had it out there. I was like, you didn't mention your podcast at all.
Get inspiration from the Living La Vida Low Carb Show. Ayy, the livinglowcarbshow.com. Woo!
Have you experienced the dreaded keto flu? Did you know that most of these symptoms are actually due to your body dumping excess electrolytes? This is where Element comes in. Element is a tasty electrolyte drink mix with everything you need and nothing you don't. That means lots of salt with no sugar. Element is formulated to help anyone with their electrolyte needs and is perfectly suited to folks following a keto, low carb, or paleo diet. Element contains a science-backed electrolyte ratio, 1,000 milligrams of sodium, 200 milligrams potassium, and 60 milligrams of magnesium, with none of the junk, no sugar, no coloring, no artificial ingredients, no gluten, no fillers, no BS. Everyone needs electrolytes, especially those on low-carb diets, or if you practice intermittent or extended fasting, if you're physically active, or sweat a lot. Add Element today and see how much better you feel and perform. Use the URL drinklmnt.com/Jimmy.